Hello and happy Teach Me Tuesday. My name is Lisa. I'm an experienced NICU nurse and a NICU nurse educator here to break down another topic for you. I'm glad to be back with you. We took the month of October off while I was traveling and being with my family and doing a couple of things that I needed to get done. So thanks for sticking with me even though we took a little break. I'm happy to be back with you on a topic actually pretty requested by y'all, which is NIVA. One thing before we dive in here, I wanted to be transparent with you as I am about everything. I haven't used NIVA since I worked in Seattle, so it's been about 8 years for me. We did trial it at the center I was currently working at, but we did not end up going with it. So I just wanted to be transparent about that. It's been a minute for me. I went back in, I've been reading and watching videos. I'm going to be tagging some of those videos in my social media, specifically Instagram this week if you want to follow along, or you can search here on YouTube for the Incubator podcast. Has a great novel one. It's more provider driven, but I do think it gives you some background. What we're going to do today is really focus on what you as a bedside NICU nurse should know, because that's my specialty and that's what I hope I'm attracting here, right, is bedside NICU nurses and what we can learn together. So NAVA stands for Neurally Adjusted Ventilatory Assist. What I like to say is NAVA is like your diaphragm's best friend. It helps your diaphragm work how it should instead of how we want it to. So the diaphragm's a muscle, and anytime we're telling something to do something when maybe it doesn't want to, or it already has its own idea of what it wants to do, it can grow tired. It can resist what you're doing, right? Like we have this idea where the baby's like kind of fighting against a ventilator. NAVA is a bridge between that, right? Where the baby still needs support, but could they be doing more on their own? So instead of relying on airway pressure or flow to trigger that breath, NAVA relies on the baby's own diaphragm. And so the diaphragm signals to that brain, okay, it's time to breathe. And then the ventilator interprets that and says, okay, let's do this together. So it's especially helpful for premature infants or anybody that's really having some respiratory distress, and it's going to let the baby drive. So let's kind of dive into what the terms are that are associated with NAVA, and then we'll talk a little bit about some of the settings. So the EDI signal is probably the biggest, the word EDI, right? This whole idea of like, what is EDI? What's the trigger? What's the peak? What's the min? We're going to go through all of that. So in general, the signal is exactly that. It's a signal of the electrical activity of the diaphragm, and it's measured in microvolts. I had to go back and be like, what is a microvolt? But trust me, it's a small amount. That's my key takeaway. And so it's generated by the brain, transmitted via the phrenic nerves, and detected by the electrodes on the NAVA catheter. I don't have a picture. I did try to find one of like what the catheter looks like on the inside. I'm going to show you a picture of the catheter, but on the inside, kind of how all those little electrodes are in there working, but everything is so small and micro. It's just crazy how all this works together. But the ventilator then takes that signal to trigger and proportionally deliver each breath. So when you go back, we've been talking a lot about vent modes, and we've been talking about pressure modes and volume modes. In pressure modes and in volume modes, it's going to give as big of a breath as it wants. What this is going to do is work together with the PEEP and the NAVA level and kind of create the best size breath for the baby. Stick with me. We're going to get through here. So the more EDI activity, the greater the baby effort, right? So maybe that's saying to the ventilator, I need you to support me more. I need you to support you less. And we're going to talk through that. So think of the EDI as the baby's respiratory vital sign. It's basically the brain's vital sign of saying, this is what I'm doing, this is what I need, and how can we work together? So with our EDI trigger, the trigger is just really telling us how sensitive the ventilator is to the diaphragm's signal. Also, sidebar, your girl can't spell diaphragm. You think I can't say it, I also can't spell it. So God be with me this week. The default setting is 0.5 microvolts, right? We just went over kind of what a microvolt is. It's a really small amount of voltage that it's trying to detect, essentially. So that lower trigger means it's more sensitive. We can miss some auto triggering that's going on. That higher trigger is less sensitive, and it may miss some weak breaths. So when your trigger is high and it's less sensitive, that baby takes like a little breath. The vent doesn't realize it, so it's not pushing out the support, right? So then you have these unsupported breaths, and we don't want the babies to have too many of that. So unlike flow triggered modes, NAVA can still synchronize when there's a leak or really small tidal volumes, which is really, really helpful, as we all know. So what do Edi Peak and Edi Min mean? If you've seen this ventilator before, this is a screenshot from their website, right? This is just a basic screen, and you can see the Edi Peak and the Edi Min are right there. I've already circled them. Let me see if I can get a pen going here. I don't know if it's going to let me, but let's see. So here's your Edi Peak and Min down here. The peak is the measure of inspiratory effort, right? It ranges from 5 to 15. If it's above 20, it's under-supported. The baby could be having a lot of work of breathing. If it's under 5, the baby is over-supported. They could be sedated, right? Essentially, you're saying to yourself, whoa, they're not getting a very big peak here, so we're not doing well. The Edi Min is that tonic diaphragmatic tone and the functional residual capacity. It's saying kind of what happens when everything is quiet. And if it's less than 3, that's great. If it's high, you got a loss of your functional residual capacity. It means we didn't have anything left. Our little reserves were gone. So the Edi trend line shows how the baby interacts with the ventilator. Rising peaks mean more work. So as you can see here on that peak, we had one peak and then it's kind of flat, which is pretty good. It means that there's not as much pressure and drive coming from that ventilator. So that's kind of what you're looking for. I want you to remember these numbers because we're going to need to know them as we move into our NAVA level, which we're going to discuss next. The NAVA level determines how much work the ventilator does versus the baby. So essentially, as a NICU nurse, I think that's just what you need to know is the higher the number, the more work the ventilator is doing. Like that's the easiest way to kind of bring this to you. It's expressed as centimeters of water per microvolt. Again, that's just like a number that I'm just like, okay, just tell me what I need to know. We're going to start low, maybe start around 1, 1.5, and watch as we go up. As the NAVA levels rise, you're going to see these PEEP plateaus, right? The Edi peak is going to stabilize, and then getting too much above that is going to suppress the baby's drive, which is not going to be helpful to us. PEEP is not a set value on NAVA, right? So that's why we have this equation here. If you want to know what your PEEP is, you need to know what your NAVA level is. You need to get those Edi peaks and mins that we just talked about, and then we're going to get our PEEP in. So I want you to remember this. We need to do our NAVA level times the Edi peak versus the Edi min plus the PEEP. I've never been more grateful that I had to help my children learn PEMDAS. So I know the order of operations for this. And in PEMDAS, we're going to do our parentheses first. So remember that. We've got our NAVA level times parentheses Edi peak versus Edi min plus your PEEP. PEMDAS is parentheses, I don't know what the E is, multiplication, divisions, PEMDAS, addition, subtraction. So that's the order we're going to do this in. Thank you, 8th grade math. And by 8th grade math, I mean 6th grade math. Okay, so here's our thing. At the bottom of our NAVA screen, as you can see here, right, we have our settings down here. And then along the right, and what's happening is our measure, what we see the baby's doing. So you've got some waveforms in there, but we're going to figure out what our PEEP is. So we need to know what our NAVA level is. Does everyone see what their NAVA level is? It's 2.0 there. So that's going to be on the outside of our parentheses. On the inside is going to be the peak minus the min. So you see the Edi peak there is 8.9. We're going to subtract 1.5 from that, close our parentheses, and then add our PEEP. Anyone see where our PEEP is? Right? It's down here in this bottom corner of 9. So we're going to take 8.9 minus 1.5, which is for 7.4. And we're going to multiply that by 2, which is times 2, 14.8. I feel like I really know math right now. I mean, do I? I'm doing this without a calculator, so let's hope so. And then we're going to add 9. So that gets us 23.8. So that is telling us our PEEP is 23.8. The PEEP is a calculated number here. But if you look at the top, the ventilator is constantly calculating it for us. So up here, right, 24, we got 23.8. Feeling good about my math skills right now. That's what you got up here. So that's a calculated value. It's not even measured, it's calculated. So keep that in mind as you go along here and kind of what you're looking at. Because if your PEEP's changing around, it probably means your Edi peaks and mins are changing around because your NAVA level is set and your PEEP is set. So important to know that as we go through. We all know what PEEP is, right? Positive end expiratory pressure. We know how it works. On NAVA, similar settings to start 5 to 6, adjust as needed. As you saw in the last one, the baby was on 9. You can have that moving around. If the Edi Min remains greater than 5, that might tell you need to increase your PEEP. So that's a great thing to know. And we really have to think about our functional residual capacity and what we want here, because we need to have like a little left over. So think of that as you go through. This apnea time to me is the most important thing to know as a NICU nurse. I think all that other stuff's important, but really what I think sets NAVA apart too is as you're adjusting the NAVA time, it gives you a quick mental picture of how the baby's doing. And that's how I always felt. If someone told me that the apnea time was 3 seconds, I was like, okay, we're still on a lot of support here. If someone told me that we were on an apnea time of 9 seconds or 13 seconds, I was like, okay, maybe we're weaning off of here. So the shorter the apnea time kind of to me is the less we trust the baby. We don't trust that the baby's going to do any of that breathing on their own. And the longer we're like, okay, we've trusted you, you're pretty much going to trigger this. I don't need to auto trigger for you. So the apnea time defines how long the ventilator waits before it switches to backup mode. All ventilators are going to have that backup mode. So the shorter apnea time is a quicker backup support. Longer apnea time is more independence. It's based on the frequency of events or agitation. If the baby goes into backup, it's not failure. It's just like what they need at that moment. So keep that in mind as you go through there. But apnea time to me and the NAVA level were like the two things. If my NAVA level was high or my apnea time was low, I was like, we're still on a lot of support. And that's your quick glance to kind of see where you're going. And I hope that helps you with kind of a mental picture. We do have backup settings. So if there's no EDI signal after the apnea time, so that means that the ventilator has not triggered the phrenic nerve to say like, hey, I'm going to breathe. Give me a supportive breath. The vent's going to do it for you. Provides pressure controlled breaths to maintain ventilation. You've got your pressure control above your PEEP. You've got a respiratory rate, and you've got an I time. So typical vent settings that we're all used to. You need to check some of that time spent in backup. If the baby's in backup all the time, maybe we've not got the correct apnea time. Additionally, if it's a change for them, my favorite thing to talk about is the change in what the baby's doing. If they weren't in it before and now they are they getting tired? Are they getting sick? Do they have other symptoms going on? Watching for those trends over time is going to be so helpful to you. So I wanted to throw it all together on one slide, just what you're looking at. If you look at the bottom of this slide, it has the words backup respiratory rate, backup pressure control above PEEP, backup I time, right? It's all there. It's telling you what's going on. It's telling you your apnea time. So our sets are on the bottom. Our measured are this first white right, my right, I think it's your right, plus what you've got going on here. They're just like a little bit different. So you see along the bottom, I've set the oxygen to 40%. I've got a PEEP of 9, a NAVA level of 2, an apnea time of 7, and EDI trigger of 0.5. To me, this baby's actually doing pretty great. Maybe we're going to get off this situation soon or be able to wean to something else. We've got a backup rate of 25, pressure control of 16 above the PEEP. So that means that your PIPs would probably come out to around 25, which is where we're at. And then we've got some measured values going on there. So that's what you're seeing on your screen. That's what settings are. That's what I would be cued into as a NICU nurse. As far as the catheter goes, remember the NAVA catheter functions as both the EDI sensor and a feeding or decompression tube. It comes in a 6 French and an 8 French. There's 2 links in the 6 French, which I know you're probably like, why is there a 49 and a 50? And that's the location of the electrodes. So it is important. There is an 8 French, and the 8 French is longer, so it's going to tell you where the electrodes are as well. When you have good placement, you really are looking at the ventilator. I mean, that's what it's doing, and I'll show you on the next slide, but you want the P waves on top to look like EKG leads and then have the disappearance on the lower leads. You want the correct color pattern, and you want to document the insertion depth. NIV-NAVA, same thing. Some people do use a secondary decompression tube. I was not in the routine practice of that, but again, it's been a minute for me, so that could be more common now. It is not a 50-50 split down this. So if you have a 6 French, it's not that 3 Frenches are made up of the EDI catheter and 3 Frenches are for your feeding. It's more like 1.5 and 4.5. It's still smaller by all means. And if your baby can get away with using an 8 French, maybe that's what you need, but it could also be too long. So let's look at the catheter a little bit more here. So on the top there, you have your feeding tube and your electrodes all in one catheter, kind of set up and ready for you, ready to go, and how it's going to go in. I've been asked before, does it feel different? It does feel different. It doesn't feel exactly the same. Maybe it feels almost more like the old school suction, initial OGs, because I think it needs to be a little stronger to the gastric acids. In the second picture here, you see the electrodes. This is from the company. This is a typical picture. You want some above and some below the diaphragm. So that's what you see here. That's what all these little dots are that are going on within here. You've got this in perfect placement. Then you've got your EDI positioning on your ventilator. It's a screen. You get to click on it and it gets to help you see what you're going on there. So use the ventilator to help ensure good placement. You want to pick up above and below, right? So getting a perfect EDI signal really starts with a well-placed catheter. So you're going to see 4 EKG-like things there. EKG-like waveforms. There's the word I want. The P waves on the top. See how tall they are? And then they're smaller on the bottom. That means you're doing great. If they're too high on all the leads, you probably are too high up. But you can see here, I know this is a small picture, but you can see how tall your P waves are and then how small they get by the last one. If you have no P waves and a dampened QRS on all the leads, you're probably too deep. So if you lose all signal here, if you're not picking anything up, you could be kinked, you could have come out, the baby could have pulled it out. This is a great screen to refer to. Highly recommend it. So how do we use NAVA? We can use it in 2 ways, both invasive and non-invasive. And invasive, it's just used with, along with your endotracheal tube. It does synchronous delivery of intubated babies. And when you're stable, you could transition to NIV-NAVA. So that's a great thing there. Similar settings, nothing amount differences really here. It typically, if you read the studies, which there are a lot of them, I have some of them. If you want them, let me know. But some of those studies really show about this idea of decreased time on the ventilator, lower PIPs. So we all know that that's probably giving us less barotrauma, less BPD in the long run. On NIV-NAVA, again, it's that same EDI signal. You can use it with the prongs or the mask. And again, you're having synchronicity and fewer extubation failures. So those are all great. And from there, you could go to CPAP or high flow as the baby grows bigger and stronger. You know how I love to talk about your escalation and de-escalation. So what can we do for troubleshooting here? If you're having high EDI with rising oxygen, maybe your catheter is not in the great place, or you need to increase your NAVA level. Low EDI, low effort, are we too sedated? Do we need to decrease our NAVA level? What do we need to do with our caffeine? What's going on with our Edi Mins? What's going on with our backup? I'm going to leave this here for you to kind of look at it. If you've got too much air in your belly, right? What can we be doing there? Is that what's happening? Do we need to put in another feeding tube? Do we need to have vent time? Do we need to be checking for air? That's going to be something you need to work on with your team to create the best kind of algorithm and care plan for these babies. So if you have no EDI catheter or signal, something's going on with your catheter. So double check that. I'm going to let you screenshot this. I'm going to stop talking. So what do we tell our parents? I think that, we've talked so much about ventilators recently and how confusing it can be if you're a unit that has a lot of ventilators or bringing things in and out. So we really need to think about telling them this is really allowing your baby to drive more of the decisions. And some babies can't do this, right? So I think of it as being like, your baby's muscles are getting stronger, their signals from their brain are getting better. So this mode is going to help those 2 things work in unison, and it's really going to be supportive of them. We're going to watch what's going on with their belly, make sure they're not too distended, and we're going to just watch the same things as always, their comfort, oxygen levels, and their breathing. So that's an overview of NAVA. Again, I didn't go into deep to some of the settings or the history behind it. There are so many great videos here on YouTube about that from kind of the guy that did it from Ohio, I believe is where that originated. Don't quote me on that, but I feel 99% sure on that. And really, there's great information out there. So NAVA is allowing the ventilator to respond to the baby instead of the baby kind of having to adjust themselves. It's translating electrical diaphragm signals into tailored support. The goal is simple. Let the baby drive and trust their signals to guide our care. So I hope this was helpful. It's been a brief overview. I really wanted to focus on what we should know as NICU nurses. Let me know if you have any questions. You can reach me here on YouTube or, of course, on any of my social medias. Have a great Tuesday. I will see you next week.